Dear friends, very good evening to all of you and greetings from Christian Medical College, Vellore, from the COVID Command Center Training Desk. As we all recover from this second wave and reflect on the lessons learned and the challenges what we have faced, we now have some experiences on the impact of COVID-19 in children. And this evening, we have our expert faculty from CMC Vellore, who will be sharing their experiences with all of you. And as we begin this session, I would like to share a short prayer, often said by our founder, Dr. Ida Scudder, which is said to gain strength from the Almighty. Father, whose life is within me, and whose love is ever about me, grant that thy life may be maintained in my life today and every day, that with gladness of heart, without haste or confusion of thought, I may go about my daily tasks, conscious of ability to meet every rightful demand, seeing the larger meaning of little things, and finding beauty and love everywhere, and in the sense of thy presence, may I walk through the hours, breathing the atmosphere of love rather than anxious striving. Amen. I now invite Dr. Ebor Jacob, who's a professor pediatric ICU at CMC Vellore, to moderate this session. Over to you, Dr. Ebor.
Thank you, Dr. Thomas. And it's my pleasure and privilege to moderate this important session on the impact of COVID-19 in children. So I'm in a room with some other people, so I'm just wearing the mask. And from the Department of Paediatrics, the speakers are three stalwarts and experts in the field. And I'm very happy to introduce my colleagues and friends. And first is Dr. Valsan Verghese. He is a professor of pediatric infectious diseases and professor of pediatrics at CMC Vellore. He is also the additional deputy chair and hospital infection control committee of CMC Vellore and a faculty at clinical epidemiology unit at Vellore. He has got a lot of his credentials and credits with research activities, mostly in vaccine trials, vaccine preventable diseases, surveillance, and biomarker studies. And he has got a lot of publications, and he is going to talk about the overview of COVID-19 in children, especially about the clinical manifestation, update, guidelines, and management. Next, I'm happy to introduce my friend Dr. Sathish Kumar, who is a consultant pediatric rheumatologist and professor of pediatrics at CMC Vellore. And he has got his pediatric rheumatology fellowship from sick kids in the University of Toronto, Canada. And he's got his area of interest are pediatric lupus and histochondritis. He's got many publications. And he's going to talk about the much talked about topic, multi-inflammatory syndrome of children, otherwise called as pediatric inflammatory syndrome, temporarily associated with COVID. And last but not the least, Dr. Winsley Rose is the professor of pediatrics and pediatric infectious disease physician at CMC Vellore. And his area of interest, all again, vaccine trials, and he's interested in a lot of rickettsial studies. And he is going to talk about the preventive strategies in COVID, to prevent COVID-19 in children. And before going to their talks, just briefly, we know the burden of the disease in children. And this is from the National CDC, just put it from their information. And the mortality rate among hospitalized children below the age of 10 years is about 2.4%, and mostly due to comorbidities. And that the pattern is similar during the two surge. I think Dr. Winsley Rose is going to talk about that. This is our pattern, and I'm not going into the details, and Dr. Winsley will elaborate that. And this is about the disease severity. And the death and mortality in ICU, this also he can elaborate. Little bit on the Missi and the PIMS tears. We have got both in the first wave and the second waves, 18 plus 25, that's about 43 children. And this is the severity pattern we have modified from the IAP or ACR guidelines. based on the phenotypes, Missi, Kawasaki-like, or MAS, or the febrile inflammatory syndromes. And based on this protocol, Dr. Sathish will elaborate on that. With this introduction, I request Dr. Valsan Verghese to go for his talk. Thank you.
Okay, so I'm the first speaker. Thank you, Dr. Ebor and Dr. Thomas, for those introductions. Okay, so I'm going to talk today about clinical presentations, management, and a bit on the updates. And this is something all of us know, that SARS-CoV-2 causes COVID-19. What has been evident over the past 1 year is the fact that, we have a lot of variants, the variants of concern and the variants of interest. And these are basically because of mutations, predominantly in the spike protein at the receptor binding domain, as well as the N-terminal. So the variants of concern for India specifically have been alpha, which is the B1.1.7, or the one first isolated in Kent. This made up 90% of Punjab samples in February to March and has been replaced in April by Delta for up to 20%. Beta is the one isolated from South Africa, Gamma, the one from Brazil, and Delta is the one we are hearing all about now. That's B1.617.2, the first isolated in Maharashtra in October 2020, made up 61% of Maharashtra samples in March, and now is the predominant strain in India, driving the second wave. So from the first wave, we know that disease severity is less in children with COVID-19. Case fatality rates very uniformly from Chinese data, US CDC, and even from Tamil Nadu last year. Case fatality rates were 0.2% in children compared to 15 to 30% in those over 8 years of age. So the question comes, is it different from the, the second wave? Is it really different? So this is data from Maharashtra comparing proportions of cases between October 2020 and Jan to March 2021. And what is interesting is that the proportions are almost very, very similar. The one difference that we find from Western data and Chinese data is that pediatrics makes up approximately 8 to 9% compared to just about 2% in Chinese data. And we have a younger population being involved. We have 47% under the age of 40 compared to 27% from China. Now, when you look at disease severity in the second wave, these are the increase in absolute numbers, and this is Velocity data. Last year, we had a total of 11,000 cases, and this year, in just 3 months alone, we've had a total of 12,000 cases. This is all ages, so there's no question that it's a more transmissible variant. Whereas if you look at the proportion of pediatric infections compared to last year, it's the same, 7% in November, 8% in April from Maharashtra. And mortality very reassuringly has not increased, comparing Maharashtra, both first wave and second wave. And from Puducherry, which has just come out on 4th of June, they've said no deaths in the 0 to 5 year age group. So to understand a bit about why children seem to be less infected or affected, look at the pathogenesis. The virus binds to the ACE2 receptor, which is then cleaved by transmembrane serine protease, leading to fusion of virus to the cell. The viral entry triggers a host immune response with cytokine release, and in the lung, interstitial and alveolar edema, exudate, microthrombi, and impaired oxygenation. So why are children less affected? Children have less epithelial expression of ACE2 and TMPRSS22 compared to adults. And while adults have more of pro-inflammatory cytokines, children have more of immunomodulatory cytokines. In addition, they have a better humoral antibody response and a better CD8 T cell activation, plus the concept of trained immunity. Innate immune memory to frequent infections and vaccinations leads to a better NK cell response to new viral infections. So this is also manifested in clinical manifestations. If you look at cough, while adults have 80% of adults present with cough, only about 50% present if children present with cough. If you were to take respiratory manifestations, 73% in children compared to 93% in adults. The other manifestations are almost the same. If you look at the WBC counts and the other lab markers, very few markers are able to predict severity or mild disease in children. In fact, abnormal markers are seen only in about 15 to 20% of children. And this particular review on the right of my screen tried to see whether it could predict mild disease, severe disease based on laboratory markers, and said they were not able to do so. CT findings, which are well documented from China, seen in children as well as adults. These include ground glass opacities, a halo sign, which is a consolidation with surrounding attenuation, or a surrounding ring of consolidation, or reverse halo, which is the picture you see here. And septations within consolidations are the crazy payment sign. They usually subpleural in the peripheral 1/3. Interestingly, 33% to over 50% of children have normal CTs, and we don't want to subject them to CT. So what about X-rays? So this is an expert consensus statement that came out last year. Interestingly, they said this is based on limited pediatric data. This has not been validated, but they classified it into typical, which is bilaterally distributed ground glass opacities or consolidation, indeterminate, which is unilateral or peripheral, and central. Same findings. Atypical would be lobar consolidation, pleural effusion, nodes. All this would be atypical or not typical of COVID-19. And here again, X-rays were normal in 33%. So imaging is not recommended for children with mild symptoms. Now, I just wanted to share some of the X-rays that you can see. Perihilar infiltrates, very non-specific. Interstitial infiltrates, which are seen with any viral pneumonia, ARDS. And then this would be a typical X-ray, which is bilateral lower lobar consolidation. This is an indeterminate X-ray, which is actually a peripheral and a central ground glass opacity. And then this round pneumonia, which is atypical and turned out to be a bacterial pneumonia. If you were to look at the confirmatory tests, this blue line over here, that's your NP-PCR, nasopharyngeal swab PCR, positive between day 3 to 7. They last for about 15 to 30 days. 50% are negative by 2 weeks. There is no virus isolation, no viable virus in these samples after day 10. Stool PCRs tend to be prolonged for about 6 to 8 weeks, but luckily, again, there is no virus isolated from that. IgG and IgM antibodies are positive in the second week. IgM lasts for 6 to 8 weeks. IgG persists for about 3 to 6 months. So what is obvious is the clinical course in children is different. They don't have the hyperinflammatory phase that you see in adults, nor the late fibrotic phase. And the other thing, when you look at differences in severity, while mild and moderate in children are the same as in adults, approximately 80%, when it comes to severe and critical disease, it's much less. While adults have about 14% severe disease, children have only 2.5. And while children have about 4 and adults have 4% critical disease, children have only 0.4. So how we manage mild, moderate, and severe disease? Mild is classically just an upper respiratory infection. Paracetamol, hydration, monitoring, stay at home, look for tachypnea. Moderate pneumonias, we admit, they are diagnosed based on fast breathing, which all our pediatricians know, for age, plus the one modification we've made in this, in all the protocols that you see. What's different in us is we've said, if you can maintain a saturation more than 94% on oxygen 2 liters, we call it moderate. Most of the guidelines talk about 90 to 94%. The problem with that is, if the saturation falls, you have to start steroids. So if you're unable to maintain saturation, if your saturation is less than 90% on oxygen 2 liters, we classify them as severe disease. So in that situation, oxygen is ramped up, broad spectrum antibiotics are started, and dexamethasone is started based on the recovery trial, which showed that deaths reduced by 35% in those mechanically ventilated, or by 20% in those receiving oxygen only. Severe and critical disease. Critical disease is ARDS, sepsis, and septic shock. This is usually looked after by our intensivists, including our, Dr. Ebor is here, high flow nasal oxygen, fluid resuscitation, vasopressors, DEXA is continued, anticoagulation is given if there's evidence of thromboembolism. And this is the point at which we start sending markers to look for multisystem inflammatory syndrome. So I'm going to talk a little bit about complicated presentations. I will give a brief overview of multisystem inflammatory syndrome, some of the atypical manifestations, what is long COVID, and what are the indirect effects. So this is the very first case that was reported. This is a baby 6-month-old with fever, rash, conjunctivitis, strawberry tongue, edema of hands and feet, a typical Kawasaki. This baby was PCR positive, was treated with IVIG and aspirin, described by a young Indian American hospital pediatrician in the US. This was followed by a 30-fold increase in Kawasaki compared to pre-COVID times, reports from Italy and France. And this accounts for 10% of all pediatric cases in the US. How is it different from pre-COVID Kawasaki? Children are older, myocarditis and pericarditis are more common. Lower platelet and lymphocyte counts are seen. Classically, Kawasaki has thrombocytosis. This is thrombocytopenia. Occurs 2 to 5 weeks after infection. Most commonly antibody positive, but can be PCR positive in about 30 to 40% depending on when it occurs. I'm going to rush over these just because Dr. Sathish is already speaking about it. What is interesting is the time frame. This is data from the US, March to Jan. You can actually see that March with their first peak, Missi came up about a month later, April to May. And then with the second peak in July, Missi came up again later in August. So these are some of the things that we should expect when our numbers go up. As far as symptomatology is concerned, Missi presents predominantly with a lot of GI symptoms compared to normal COVID. Respiratory symptoms are much less common. Among the Kawasaki features, 50% have conjunctivitis and rash. Oral changes are seen in about 30%, and the least common manifestations are edema and adenopathy. A complete Kawasaki is often seen in only about 20 to 40%. About half of them will present with shock and 20% with renal failure. Compared to normal COVID, here we have markedly increased inflammatory markers, 60% increase in other markers such as D-dimer, ferritin, fibrinogen, about 40% of cardiac enzyme elevation, myocardial dysfunction, and about 15% of coronary artery changes. So the definition we follow is the WHO definition. Dr. Sathish will elaborate about that as well as the treatment. The one thing I wanted to point out is that just compared 3 series of cases, 1 from the US and 3 from India in the last year, 19 from Kanchi Kamakoti, 23 from Mumbai, and 17 from our own PICU. What is interesting is that the primary modality of treatment has been IVIG and or steroids. Immune modulators have been used only in a minority. And that too, not even that much in our own ICU. Outcomes are almost uniformly good. Time from treatment to fever resolution is within a week. Cardiac markers resolve in 2 weeks, and LV function recovery 90% in 30 days and nearly 100% by 90 days. Similarly for coronary artery aneurysms. Now, because ACE2 receptors are present in a lot of systems, these are some of the other manifestations that have been documented with COVID-19: conjunctivitis without multisystem inflammatory syndrome, gross hematuria, new onset nephrotic, rhabdomyolysis, orchidoepididymitis, and a host of gastrointestinal manifestations such as neck, intussusception, acute mesenteric adenopathy, pancreatitis, and cholestatic jaundice. Neurological manifestations can be seen even without Missi. This is data published this March in JAMA Neurology. This is from a COVID registry in the US. They had 1,695 patients, children. Of these, 22% had neurological involvement. Only 1/3 of these were actually Missi. So these are symptoms that you can expect to see. I'll just walk you through the graph. The gray one is less than 5 years. The middle one, 5 to 12, and the dark bar is the older, 13 to 20. If you look at the symptomatology, seizures more common in younger children, loss of taste and smell common in older over 13, headache in older children, altered sensorium across the board. And then in these children, 88% of these had transient symptoms that resolved. Only 12% had life-threatening conditions. This included encephalopathy, stroke, demyelination, Guillain-Barré syndrome, and acute cerebral edema. 1/3 died, and half of the survivors had sequelae. The other atypical manifestations are dermatological, which can include chilblain lesions or COVID toes. These are itchy erythematous papules on the toes of adolescents or young adults. They occur 1 week to 2 months after respiratory symptoms. By that time, often they are PCR and IgG negative. Some have been IgA positive. On electron microscopy or biopsy, immunohistochemistry has been positive for spike protein and viral particles have been seen. It's thought to be due to an immune-mediated vasculitis. Other lesions that have been described are purpura, maculopapular rash, vesicobullous rash, eczema, urticaria, and erythema multiforme. Long COVID has been documented in a lot of adults, but only in a few of children. 3 small case series so far. It's often seen in adolescents. The longest duration is 8 months after COVID diagnosis. The commonest symptom is fatigue, myalgia, chronic cough, dyspnea, and less commonly, abdominal pain, deranged taste and smell. Similar symptoms in other family members suggest a predisposing environmental component or stress due to the lockdown. And when we are talking about the lockdown, we should not forget the indirect effects. Food insecurity and malnutrition. We all know how much the midday meal scheme has contributed to decreasing malnutrition in Tamil Nadu. And this food insecurity can actually lead to affect more than 200 million children globally. As pediatricians, we all deal with children from higher socioeconomic status, and in these children, decreased physical activity leads to obesity. In addition, increased screen time. So the picture on your right shows on the left, screen time, daily screen time before lockdown has literally gone more than double during the lockdown. And why is that an issue? Because there's a lot of data saying that increased screen time is associated with increased incidence of myopia. In adolescents, issues of mental health, anxiety, antisocial behavior, addiction, domestic violence, they are prone to domestic violence and at risk of sexual abuse. In addition, the loss of education has an effect on future socioeconomic status. And now we are actually seeing that child labor, especially even in Tamil Nadu, a recent survey has shown that that has gone up by nearly 50% pre-pandemic. So one of the options is to open the schools, but when you open the schools, you are going to see outbreaks. So this is in Austria, Berlin, sorry, and this is before school closure. There were 3 outbreaks per week, 6 cases per outbreak. After reopening, 2 outbreaks per week, 4 cases per outbreak. And you can say these are small numbers. Why are we worried about it? It's likely to be mild. But when you look at who's affected, these yellow bars, these are adults over the age of 21. So basically the teachers and the people who look after the children, these are the people who are at risk. So how do we safely open schools? The CDC has a website, a mitigation toolkit, which says use masks, social distancing, alternate class busing, maintaining distances within the classroom. All this is there in the IAP guideline, which also talks about, what are the epidemiological, shall we say, indications for reopening schools, and that they recommend a case positivity rate less than 5%, cases decreasing for 2 weeks, and number of new cases per day less than 20 per lakh population continuously for 2 weeks. So this is going to take a little while, but while I was looking at the CDC website, I came across this on the top, this Band-Aid and this logo that said, get a vaccine. So I thought maybe, we should look at what is the current status of vaccines for children. Pfizer and Moderna, the mRNA vaccines, have completed their trials in 12 to 17 years. Pfizer is authorized for use in the US, Europe, Canada, and Singapore. They have started trials in 6 months to 11 years of age from March 2021. AstraZeneca has started trials of its vaccine in 6 to 17-year-olds in February. And because the government of India says we probably don't need bridging studies anymore, this data will help to inform how we vaccinate our children. And on 16th April 2021, the UK has started vaccinating pregnant women with Pfizer and Moderna based on safety data from the US. Now, you may ask, as a pediatrician, why should I be interested in vaccinating pregnant women? And this is the answer. So vaccinating, this is not yet a recommendation, but there's a lot of push for this. And vaccinating pregnant women actually gives rise to antibodies that can be transferred across the placenta, especially if they've been vaccinated at 6 weeks prior to delivery. And I'm glad to know that this is something we are doing, that is vaccinating lactating mothers. So this again shows that, if you vaccinate lactating mothers, and these were with Pfizer vaccine, antibodies were measured at 21 days. And these antibodies were present in breast milk for up to 80 days, nearly 3 months. And this is again followed by another study showing very similar data from Israel. So to end, I just wanted to end by saying COVID-19 is less severe in children than in adults. Multisystem inflammatory syndrome is treatable with medications available in India. Vaccinating pregnant women can offer us options for protecting infants. And although we are still learning a lot about the infection and the disease, at least the future is not entirely bleak. Thank you. Over to Dr. Sathish.
And now over to Dr. Sathish for Missi presentation.
Good afternoon, friends. Thank you very much for giving me this opportunity to talk about Missi. As you know that Missi has come in a big way now. So I am going to concentrate only on the diagnosis and the management. I'm going to tell you about this nomenclature, what is Missi, PIMS, TS. When you suspect, when you see a child in your OPD or in the emergency room, what are the treatment guidelines and what is our CMC protocol? So as Dr. Valsan has already said that early April 2020, the first case series came from France, 16 children presented like Kawasaki disease, which all of them had COVID. So they called them as Kawa COVID. Then the first paper from the UK, 58 children, which is published in JAMA in June, followed by a huge series of children, 186 children from US. They call them as multisystem inflammatory syndrome in US children and adolescents. So when you look into the nomenclature, it's all the same disease told by different people. You all know that Europeans does not agree with Americans. American does not agree with Europeans. So Americans said as Missi, CDC, or PCH. UK, they call us PIMS TS, and WHO call us Missi. So if you look into all the three definitions, I think the WHO's definition is very clear and simple. Anybody can understand. So any child fever more than 3 days and 2 of the following. This is what very, very important. Clinically, they have rash, bilateral non-prolonged conjunctivitis, or oral mucocutaneous inflammatory changes. They can present with hypotension or shock, myocardial dysfunction, pericarditis, valvulitis. They can present with coagulopathy. They can present with GA symptoms like diarrhea, vomiting, and abdominal pain. And they all will have raised inflammatory markers, very high CRP, very high ESR, procalcitonin. Very important thing in our situation in India, where you have a lot of tropical diseases, there should be no obvious microbiological cause for inflammation, including bacterial sepsis, streptococcal or staphylococcal shock syndrome. And evidence of COVID-19, either serology is positive or RT-PCR is positive, or contact with person with COVID-19. So when you look into this criteria, this is not very specific for diagnosing a Missi. So in India, we still see a lot of enteric fever, shigellosis, acute appendicitis. If you look into these 3 things, all these children will have fever. They may not have this typical rash, oral changes, and all the classical KD-like phenotype. They can present with shock. They can have coagulopathy. They can have abdominal pain, diarrhea, vomiting. So all can be present. So if you look in a child with the enteric fever, they will fulfill the criteria for Missi. Obviously, blood culture will grow depending on how you collect the blood culture. Sometimes may not be positive also. And remember that this COVID-19, now we all are exposed to COVID. It is there complete in the community. So nothing like I'm not exposed. So likely contact of patients with COVID-19 will be there for most of the children who comes to you. So if you look into this, all these things can present like Missi. So if you take dengue and rickettsial infections, so again, dengue can present the shock, they can present the myocardial dysfunction, they can present the coagulopathy, they can have severe abdominal pain, dengue with warning sign. And remember that at least in dengue, usually because this virus, CRP, procalcitonin will be negative, but rickettsial infection, again, it can be high. Again, other cultures, dengue is easy to diagnose because we have very specific, non-specific antigen test. Depending on the day, IgM and IgG will be positive. Again, contact with COVID can be positive. So again, dengue rickettsial infection can fulfill this criteria. So what you should know is you should not miss out. The reason I'm talking this is you should not miss out because they fulfill the criteria for Missi doesn't mean that this child has got Missi. We have seen children with rickettsial infection. We have seen children with dengue. We have seen children presenting with toxic shock syndrome. All will fulfill the criteria for Missi. But again, so overdiagnosis of Missi should not be there. But keep Missi in the back of the mind because if somebody comes with shock, you think, okay, it is Missi. You give huge dose of steroids. It was not good for the child. Epidemiology, so it is severe Missi syndrome occurs in estimated about 2 per 1 lakh children. So it's not very common, 2 per 1 lakh children. And almost 80% of them need ICU care. The mortality rate is less than 2%. So it's a very good disease. If you diagnose and identify early and treat it, they do very well. So after the initial case series, there are a lot of reports started to come from various parts of the country. You can see here the last 3 are from India. Initially, there are some case reports came. Then there are 2-3 case series is also there. So what else they say? So when you look into the presentations, various countries reported the commonest presentation. The age is usually older children, and they can present with almost 60% of them presents like with Kawasaki-like disease. And as I said, that SARS-CoV-2 PCR can be up to 45% positive, but antibody is positive in 75%. 2/3 of them presents with cardiac dysfunction. They can have, again, 65% have gastrointestinal. So when you look into the Missi, it is not a one disease. We have to consider as a 3 clinical phenotypes. So the first phenotype is the febrile inflammatory state, where they have only fever and mild symptoms. The inflammatory markers are elevated, but the signs of severe multisystem involvement is absent. Second group is Kawasaki-like illness. They can have either complete KD type or incomplete Kawasaki disease. Again, they don't develop shock or severe multisystem involvement. The severe Missi is the one which presents with multisystem involvement, cardiac involvement, and shock are very common. And they have very high inflammatory markers. So these are the 3 basic phenotypes. So again, is the phenotype is very separate? No, there is a study by the British Paediatric Surveillance Unit where they found out there are 268 children with PIMS-TS. This is from Europe. They found out that you can see the PIMS-TS can have Kawasaki-like presentation. They can have PIMS-TS with TSS, toxic shock syndrome. Some children have toxic shock syndrome-like presentation, Kawasaki, and PIMS-TS only. So the learning point is, so it is not, you have to approach like a syndromic approach. So when you look into this KD like presentation in PIMS-TS and your classic pre-pandemic KD we call, if you look into that, this PIMS-TS with KD is usually in the older age group. They have a lot of GI symptoms. They have cardiac dysfunction, coagulopathy, shock, macrophage activation syndrome, and very high CRP. CRP is more than 100. Usually the coronary artery abnormalities, typically what you see in the KD is little less in PIMS-TS associated with KD. So this is what the pathogenesis, what you usually say is after the adult peak comes down, this Missi goes up because we assume it is not due to acute COVID infection, is a post-inflammatory response. It usually happens 4 to 6 weeks after the peak curve. So when you want to look into pathogenesis, this is what Valsan showed. Everybody, they can be initially can be asymptomatic or mildly symptomatic. There is no pulmonary infection stage in children due to various reasons, lack of ACE2 receptors and other factors. Then what happens is when they get into the SARS-CoV-2, in some children who are having some genetic problem, their macrophage gets activated. from the SARS-CoV-2 infection. This is a stage of hyperinflammatory phase where the T cells are activated and a lot of cytokines, pro-inflammatory cytokines are produced, leading to cytokine storm. Then the B cells, they also produce autoreactive T cells and elicit the immune response in a genetically predisposed child. So remember, all the children with SARS-CoV-2 will not go into Missi. Those children, there's a lot of studies now going on why some children alone develop Missi when most of the children are exposed to SARS-CoV-2. So leading to all the typical presentation of Missi. So when will you suspect Missi in a child? So anybody who has got fever more than 4 days without any focus of infection. We are seeing a lot of children in the OPDs nowadays. 4 days fever without no focus, no running nose, no cough. Or if they have fever more than 3 days, they can present with typical Kawasaki-like illness, mucocutaneous. They can present with cardiopulmonary. They can have chest pain, breathing difficulty, shock, gastrointestinal symptoms like nausea, vomiting, diarrhea, and abdominal pain. Neurology, Valsan has told about the neurological presentation they also can have, and they can present with lymphadenopathy, hypotension, or hypoperfusion. All those things can present. So any child. So if you take in your routine things, what we teach is anybody who comes like sepsis with septic shock, nowadays you should consider Missi when this pandemic is going on. So these are some of the rashes we are seeing. This is a typical non-prolonged conjunctivitis rash, which is seen in typically in the Kawasaki disease, and oral changes in one of our child with KD presentation. These are the rash, the peripheral edema, which can be seen in Kawasaki-like presentation. So most of the time, the rash is typically of the Kawasaki-like disease. So investigation. So what will you do when you suspect MIC? The child come to the OPD with only with fever, without any focus. I think you should do CBC, ESR, CRP, LFT, electrolytes, creatinine, blood culture, and because in India is tropical country, if you are suspecting rickettsial infection, you do Vidal, Wheelfelix, and urine routine and blood culture. These are things you should do. So something called positive screen. If the children has CRP, especially in BC children, CRP more than 100, high ESR, lymphocyte count is low, platelets are less than 150,000. If there is hyponatremia, neutrophilia, and hypoalbuminemia, you should suspect whether this child has got Missi. Then, if they present a severe manifestation to casualty or emergency with shock, then we should do the other inflammatory markers like procal, PT, APTT, D-dimer, fibrinogen, LDH, triglyceride, cytokine panel. Not routinely we do unless you have facility to do that. And definitely you have to do SARS-CoV-2 serology. So RT-PCR may be negative. You may have an antibody positive. So no point in doing all these investigations on day 1, because sometimes if you do day 1 or day 3, only fever, no shock, D-dimer comes as 1000, what will you do? You're not going to act anything on that. It does not predict. We have seen so many children coming like that, D-dimer high, they go home without any severe manifestations. So when I come to the treatment guidelines, because it's a new disease, the treatment guidelines keeps on coming. The first guidelines came from the UK in September 2020. Then in July, American College of Rheumatology gave the first version 1. But remember now again in April 2021, version 2 from ACR has come. So what they say there is, as remdesivir, no role in the management of Missi because it is usually post-inflammatory. And remember, RT-PCR positivity does not make you to give remdesivir. RT-PCR can pick up a dead DNA also. And we also know that RT-PCR can be positive for 2 to 3 months in children who has got COVID. So remdesivir has got no role. Empirical antibiotics as per your local protocols. And ACR says that you divide the children presenting with shock or without shock. So children who are presenting with shock and life-threatening disease, organ-threatening disease, you give IVIG plus methylprednisolone. If they are refractory, that means there is no improvement within 24 to 48 hours, you consider high-dose methylprednisolone, that is 30 milligram per kilogram, and you give anakinra, which is IL-1 blocker, which is not available in India. If they don't have shock, they want to give only with IVIG, and if there is refractory, then you consider giving low-dose methylprednisolone or anakinra. So this is the guidelines which came from the ACR in April. So what did they talk about anticoagulation and antiplatelet? Everybody should receive aspirin if they have thrombocytosis and coronary artery aneurysm. Is like a KD-like picture. Coronary artery aneurysm Z-score more than 2.5. continue the aspirin till the coronary artery aneurysm is resolved, or normal echo, which is confirmed at 6 weeks. Low molecular weight heparin, they given very classical when to use Z-score more than 10. That means large aneurysm, documented thrombosis. If they have severe LV dysfunction secondary to myocarditis less than 35%. And they talked about hyperinflammation, like HLH like picture, where they can present with the ARDS, shock or cardiac dysfunction, elevated inflammatory markers, low lymphocyte count. Then there is like a HLH like presentation. You give high dose steroids initially and give anakinra, again IL-1 blockers, or tocilizumab, IL-6 blocker, which is available in India. So again, when you look into read about the news, you will getting new protocols. AIMS protocol came in 2021, and Ministry of Health, Family and Welfare in May 2021. Remember that they all just divided into two, with shock, without shock. With shock, they want to give IVIG plus steroids. Without shock, they want to give here, they said you give either steroid or you give IVIG as per the availability. If there is no improvement, you can repeat IVIG or high dose methylprednisolone. So this is what from the AIMS protocol. Then IAP has given a protocol in 2021. Again, it's also similar. So they have two groups. Either you divide them with shock, without shock. With shock, you give IVIG and you give high dose steroids, 10 to 30 milligram per kg of steroids. And you look for the echo. If there is no shock or life-threatening disease, you give IVIG. Again, you give IVIG and you give 2 milligram per kilogram of steroids. So this is what they say. If there is no improvement, you give tocilizumab, infliximab, or anakinra. So this is almost similar to the protocol proposed by the American College of Rheumatology. So this is the updated protocol of IAP, which is going to get published tomorrow. This is a slide yesterday. I got it from Dr. Tanu Singhal, who is there in the task force of IAP. So now IAP is coming to the phenotype-like presentation. If somebody comes with shock phenotype, or you have KD phenotype, or you have mild Missi phenotype. So if you have a shock phenotype, they want to give high-dose methylprednisolone and IVIG, empirical antibiotics. If the child is getting better, they want to come down on treatment to 2 milligram. And biologics like tocilizumab, we discussed with the expert. KD phenotype, they want to give IVIG plus steroids low dose, 2 mg per kg. If they're not settling, to give high dose steroids. Mild Missi, there is no shock. This is the condition like the febrile inflammatory state. They have high fever, but no shock, no cardiac phenotype, no myocardial dysfunction. Either you observe or you give methylprednisolone or oral prednisolone 1 to 2 mg per kg for 3 to 5 days and look for the alternate and try to exclude the alternative diagnosis. So this is the IAP protocol, which is going to get published in a couple of days. It will come. And this is new. 9th June 2021, Lancet COVID-19 Commission paper, Indian Task Force. You can see this is from the Paediatrics group. You can see Winsley is also part of the task group. So how to prepare for the COVID-19 is a very nice paper, about some 13-14 pages. I urge everybody to go through this paper. So what do they say in that paper? They looked into all the criteria and all the available literature. So what they said, they also said that mild Missi means only fever, stable. And you do the level 1 and you give low dose steroids, and also to give aspirin for this group, even though they don't have any other clinical features, to give low dose aspirin. If they have severe Missi, they're given the criteria for that: respiratory distress, neurological deficit, MODS, cardiac dysfunction. Here again, they have given IVIG and low dose steroids initially. If it is no improvement, to go to high dose steroids. So based on these various protocols, okay, telling the different things. So from our team, along with Dr. Ebor, Winsley, and myself, because we are seeing different phenotypes, what we see. This is a protocol Ebor has already showed you. So we have divided them into 4 phenotypes. One is a typical febrile inflammatory state. This is similar to a mild Missi. Then the group which comes with shock. Again, depending on the severity of the shock, you should consider the treatment. Okay, if it's a mild shock, only steroids. If they have severe shock or end organ dysfunction, we can give IVIG and steroids. KD phenotype, IVIG has to be there because they can more prone to have coronary artery aneurysm in the long term. If they come with MAS or HLH phenotype, is same, methylprednisolone and tocilizumab. So discharge criteria, so make sure You see the children after 1 week and make sure that all the things are come to normal. You give steroids for 2 to 3 weeks and stop. Long-term follow-up, if they have a echo abnormality, those children has to be followed for long-term with serial monitoring of the echo. And if they have, as I already told you, they have severe dysfunction, if they have Z-score more than 10, you should consider continuing enoxaparin. So key message, 3 phenotypes very common: febrile phenotype, Kawasaki phenotype, and shock phenotype. Overdiagnosis or delayed diagnosis of Missi to be avoided. Remember that in our country, we should rule out all the other conditions before you start treating like Missi. And the treatment has to be tailored according to the phenotype. All the children does not need IVIG or high dose steroids. And it's better to have a team to treat these children. I will stop it here. Thank you. Thank you, Ebor.
Thank you, Dr. Sathish. And you can continue to answer that probably, Sathish and Dr.
Sure.
Valsan. And I request Dr. Winsley Rose to talk about the preventive strategies in children, of COVID in children. Over to Dr. Rose.
So I'm going to just talk very briefly about prevention of COVID-19 in children. So what I'm going to do is to actually first figure out, actually, do we need to prevent COVID-19 in children? And if so, like basically, why do we need to prevent COVID-19 in children? And then a little bit about how we can prevent children from developing COVID-19. So this is actually a slide which actually shows the age distribution of COVID-19 deaths by 5-year age groups. So, I mean, this is actually all over the world. If you actually look at this slide, the number of deaths actually is very, very little as compared to older age groups. And the numbers increase as the age increases. Compare that with the COVID-19 cases. If you look at the COVID-19 cases, this almost follows like one bell-shaped curve with the people in the middle. That's the healthy adult age group having the most number of cases, and the number of cases being lower in the extremes of ages. So I've sort of tried to overlap both these slides. And if you look at it, the bulk of the cases actually happen here, but the bulk of the deaths are in the older age group. Just to show you that actually among children, even though there is disease, the mortality is actually very little. Now, this is basically looking at, so what you can see in the background in the pale blue is actually the proportion of the population in these age groups. So if you look at the proportion of the population, it's not like this bar graph actually follows the proportion of the population. So even though the proportion of the population in younger ages is actually more, the number of cases is actually less compared to the population size in that particular age group. It just basically goes to show that children, not only do they, their mortality is less, even their disease acquisition is also less compared to the middle age group. This is see, we don't have good data like this from India. This is data from America, which actually shows the proportion of the population which is positive for COVID-19 in children. So when they started off, only 2.6% of all the positive COVID cases were because of were in children, whereas when it sort of last week, it became about 17.2% of the cases. So it just goes to show that, as we go later on in the pandemic, more and more children are actually getting infected in proportion to the rest of the population. So this is again from data from the United States, which sort of came out maybe about last week. So 14% of them, I just want you to just concentrate on these red oval highlighted areas. So 14% of children were positive. Out of which, if you look at the percentage of hospitalizations, it's between 1.4 and 3.2. So about 2 to 3% actually of all the hospitalizations were in children, even though 14% of children got infected. And of those who died, if you look at the proportion of child deaths among all those people who died of COVID, it's anywhere between 0 and 0.2%, 0.23%. So you can see that even though children get infected, children are hospitalized much less, and very few actually die because of COVID. Now, I'll just give you some information from our own experience at CMC. This is we have data from June of 2020, and if you can, it sort of mirrors the wave in India, which is actually there on the top left corner. That's actually the national statistics. So it sort of mirrors that. And over the past couple of months, like the rest of the country, we've also seen a big wave, even among children. But what I want you to see is that whether, so I sort of, it's sort of very difficult to figure out what is a wave. I've sort of classified it into wave 1 and wave 2. Wave 1 up to February, because March is when the cases started going up again. So wave 2 I've taken from March to May 2021. If you look at, we've classified it into asymptomatic or mild and moderate, severe, critical, and then finally MISC also. To look at it, almost 90%, whether it's wave 1 or wave 2, 90% of them had only mild or asymptomatic cases. And among the severe, critical, and Missi children, it's about 8%. And whether it's wave 1 or wave 2, it actually makes very little difference. So whatever the variant is, whatever the wave is, it's not like the children are actually sicker during this second wave. I think Dr. Valsan and Sathish had mentioned about Missi. Like Sathish had mentioned, actually, we've had about 30-40 patients with Missi who've been admitted in our hospital, but these are all children who are COVID, PCR positive. So that proportion is like, the Missis with PCR, which is positive, is actually much less. And it seems like a bigger proportion of those with Missi were positive by PCR in the first wave as compared to the second wave. I just want to put this mortality data from our own experience also. About 10 children died out of the 988 children that were positive by PCR. About 10 children died. And of the lot who died, the ones in red are all less than 1 year of age. And there were 2 children who were actually 1 year of age. And the rest were in their, like 1 4-year-old, then the rest were 13 and 14 years of age. Almost all of them, except the 37-day-old, whom we are not sure whether the child had primary HLH or not, all the rest actually had very severe comorbidities, which itself is actually reason enough for them to have died. So the bottom line is, if you do not have any underlying comorbidities, the risk of death is also very low. And if you look at some data from China, there is data to say that among the severe critical disease, it's the younger infants who are actually more at risk of dying. I think a lot has been said about Missi. Just to point out that Missi is actually more common in the 5 to 9 age group and the 10 to 15 age group. So it's in the older age group that Missi is more common, and Missi follows a wave of COVID, and it is more common among male children. So in short, children generally have lesser disease. They also have less severe disease and have a lower mortality. So of the pediatric age group, the infants are likely to become sicker, and one needs to be concerned about Missi in older children, which is a rare, like Sathish mentioned, it's like 2 in a lakh, which is a rare but serious condition. And there is no difference between waves 1 and 2. So do we need to prevent COVID-19 in children? So I think, it's not like children do not become sick. They do become sick, but the proportion is much smaller. But when you have a large wave, that number actually is quite a significant number. So children can become sick, more so with infants. And we do not have a vaccine right now for the children. So children right now are a susceptible pool of the population. And children also can form an important transmission pool, especially to unvaccinated adults within the household. And once we start schools, the transmission among children also is likely to increase. And also, imagine a child having COVID and being isolated or quarantined. It's not a fun thing for those children. I think for all these reasons, I think it is important to prevent COVID-19 in children, even though they have less disease and less deaths. So how do we protect children? So I think it just follows the same basic tenets of prevention of COVID-19, whether it be adults or children. So it's basic use of masking, distancing, washing hands, and the use of vaccines. I really like this this WHO chart, which actually talks about the 3 things that you need to be mindful of. That is the location where you are. If you're inside a inside a closed building, the likelihood of transmission is higher compared to if you're in an open space. So if children were to congregate, it's probably better they congregate outside and keep distance. I mean, the closer you are, the more likelihood of transmission. So the further you are, the less likelihood of transmission. So if children can play together, they can probably maintain distance and play outside. And duration of contact. So try and minimize the periods of contact, close contact, as little as possible. So if we are sort of mindful of these, then it is possible for us to prevent ourselves and our children to prevent them from developing COVID disease. So what about masks? I mean, there are various recommendations. The WHO very categorically states mask is to be used only after 5 years of age, whereas CDC and the IAP actually recommend over 2 years of age. I think the concern is the use of mask and the safety and the implications that it has on social interactions and the mental development of the child is what actually determines whether you want to use the mask in a younger child or not. Among 6 to 11 years, WHO recommends that it should be personalized. I mean, you should assess the risk, and if the risk is high enough, then you should use the mask. But about 12 years of age, the mask should be used as for adults. And what mask to use? So WHO recommends fabric mask for the healthy and medical mask only for those with underlying health conditions. And if a child is infected with COVID, then you should use a medical mask. CDC also recommends cloth masks or disposable masks. They also recommend double mask. IAP recommends a simple surgical mask. When would you use it? So WHO says if you're going to have a contact which is less than, if you cannot ensure a contact of distance of more than 1 meter distance, then you should use a mask. CDC says anywhere in public and in the house if somebody is infected. So I think the basic tenets are if you remember this slide that I showed you, that the location, the proximity, and the duration of the exposure. So depending upon all that, we can actually decide whether a mask needs to be used or not. And distancing, again, in anything, I mean, I think safe to say that if you're more than 2 meters away from another person, the likelihood of getting transmitted is actually very little. And washing hands. I mean, I think adults should show the way, because no child, I mean, you can teach a child all that you want, but if you don't follow it, it's very unlikely that the child will follow whatever you teach. I mean, they will follow what you do rather than what you tell them to do. So I think adults should show the way. So alcohol hand sanitizer is useful if it's used, if it's more than 60% alcohol. And hand washing with soap, where you wet, lather, scrub, rinse, and dry. If you follow all that, that's also useful. Alcohol hand sanitizer you use for about 20 seconds. Hand washing, at least 40 seconds. And you should teach them when they should wash their hands: after using the bathroom, before eating, after touching pets, after playing outside, after coughing, sneezing, or blowing their nose, and before and after wearing a mask. So washing hands is important. Now, vaccines, Dr. Valsan touched upon this as well. So more than, I mean, right now we don't have a vaccine in India which is actually, can be used for children. So in the United States, more than 12 years of age, Pfizer vaccine is available. It's 2 doses, 3 weeks apart. and it's got excellent efficacy. In fact, they claim 100% efficacy and very good antibody responses in children between 12 and 15 years of age. Now, this is even better than those who are 16 and above, that 100% efficacy. And studies are underway between 6 months and 11 years of age. Covaxin, the trial started this month for 2 to 18-year-olds. AstraZeneca and Johnson & Johnson, both are adenoviral vector vaccines. They started their study in February, but they paused the trial in April because of the increased risk of clots among younger adults. I mean, it's not a big risk because it was only 30 in 15.8 million doses. But because there was some issues with younger adults, they paused the trial. So vaccines are other things. So I thought I'll just talk a little bit about prevention in certain specific situations. So what about COVID-19 and breastfeeding? Now, breast milk transmission there is no documented transmission from breast milk. Even though you can find the viral particles in breast milk, there is really no documented transmission. So mothers should continue breastfeeding unless they are too sick to breastfeed. Kangaroo mother care is also advised. And if a mother is suspected to be COVID positive or is COVID positive, what should they do? So one, they should wash their hands frequently with soap and water or use alcohol-based hand rub, especially before touching the baby. They should wear a medical mask during their contact with the baby, including while feeding. They should always sneeze or cough into a tissue and dispose of it immediately and wash hands again. And routinely clean and disinfect surfaces that the mother has touched. So basically, breastfeeding should be continued. What if a family member has COVID? So it's best to actually isolate that family member from the rest of the family and maintain at least a 2-meter distance from that person. And the child should always maintain a 2-meter distance. And if the child is going to get any closer than that, the child should always wear a mask, and the person who is infected also should always wear a mask. Now, and the room itself, like I told you, the more closed it is, the more risk of transmission. So the more airy the rooms are, the lesser risk of transmission. Now, what if a child has COVID-19? This child should wear a medical mask as long as they can tolerate it. And the child should be isolated as much as possible. And medical advice should be sought if the child starts to feel unwell, even if the symptoms are mild. And any family member or caregiver who comes within 1 to 2 meters of the sick child at home should also wear a mask. So I'll just summarize here. So one, children are not affected severely with COVID-19. And prevention in children actually follows the basic tenets of COVID-19 prevention, which is masking, hand washing, maintaining distance, and vaccination. And children are always much more vulnerable to the ill effects of social distancing and masking. So I mean, we have to balance these ill effects with the advantages of masking, and also take into account the many challenges faced by the children, especially with regards to social isolation, the lack of proper education, and the family's economic burden, which actually impinges on the child's well-being. Dr. Valsan already mentioned a list of things which children are going through. So with that, I'll stop, and I guess we're happy to take questions beyond this. Thank you.
Thank you, Dr. Winsley. Thank you, friends, for a wonderful session of overview of the impact of COVID in children. So a lot of questions are there. I'll start with the questions to Dr. Winsley Rose. You talked about medical mask and what is the difference between a medical mask and a surgical mask? Is there any difference?
So I think it's just that third 3-ply mask, which is basically a surgical mask. I think it's equivalent to the surgical mask.
Sure. And yes, no problem. That's we talked about the breastfeeding. It doesn't protect of a breastfeeding infant by an infected or a vaccinated mother.
So we don't know yet. I mean, Dr. Valsan showed some data about I mean, if there is a mother who's been infected, there can be some antibodies within that breast milk. But whether it really makes a difference to the child getting infected or not, we don't have that much data to say that. But it's important because the advantages of breastfeeding definitely outweighs the risks of actually not breastfeeding. So if the mother and breastfeeding there is no transmission through the breast milk. So if the mother can actually wear a mask and keep the hands clean while hand washing, while handling the baby, that itself should be sufficient enough. Plus, the fact that even if a child develops COVID, the risk of severe disease is also very low. So all that put together, I think it's important to continue breastfeeding.
Sure.
I just add to that. We don't know how long the antibodies last after infection. We know that antibody levels are higher after vaccination compared to infection. So, but then, if you're talking about correlate or protection, you don't really know exactly, as Winsley said, whether the, breastfeeding from an infected mother as opposed to a vaccinated mother has more protection or less protection. But, there's no the point is there's no risk with breastfeeding, provided you're wearing a mask and you're not transmitting through respiratory secretions.
Okay, so that's a question on Missi in neonates. I don't have a data from our institute is about Missi in neonates. If a pregnant mother is affected by COVID, what's the risk of baby developing COVID antibiotics? Missi in neonates.
See, Missi in neonates is a rare compared to the Missi what we see in the older children also. But there are a lot of reports of Missi children, the newborn presenting with breathing difficulty, and the antibody is positive, high D dimers, high CRP. Again, they respond well to IVIG and steroids. There are some case reports, even Missi presenting the newborn with coronary artery dilatations. Mother had COVID during the antenatal period. We have some case reports like that also. But in our institute, whatever I have talked to our neonatologists, they have 2 patients who had breathing difficulty and both of them settled well.
Sure. Yeah, that's right. And there was about a clinical case scenarios. Dr. Sathish has already discussed about that. That is one of the important presentation, like an acute abdomen in Missi. So that we have seen as well. Is a 9-year-old child that Dr. Samia Razvi has put about a 9-year child who's presented like an acute abdomen and underwent an appendectomy and has come now antibodies positive in shock. And 2D echo being done, and what is the safety of IVIG and steroids in a fresh post-op patient? Dr. Sathish has already answered that. Yes, if the patient is in shock, we need to know the cardiac status, IVIG, and a low-dose steroids probably safe with the broad-spectrum antibiotics. And the same thing, and Dr. Manoj has asked about whether prednisolone, methyl prednisolone has to be given before IVIG. That's also Dr. Sathish has answered. Yes, it's better, especially in a shock patient in severe shock. You give methyl prednisolone followed by the IVIG. And there were some questions on vaccines. Dr. Valsan has already mentioned and answered that. And I would request Dr. Valsan to talk about the flu shot. Many people asked about that. And what is this? Does it reduce the severity?
So, no. The short answer is no. The interesting thing is, we are seeing a lot less of flu, especially because, children have not gone to school, adults have been masking. So that is one of the issues that you will face once you have, universal vaccination. So in the sense that you are likely to have your flu again once you start taking off your masks. But, flu vaccination protecting against COVID, no. I know people have spoken about it. I know, it's been recommended by some bodies, but there's no evidence that flu vaccine is going to help you against COVID.
Sure. Thank you. And somebody has asked about the cutoff values of ferritin, D-dimer, and anti-pro-PNB. In our lab, its ferritin is, I think, 22 to 300, less than 300 nanogram per ml, right? And D-dimer, we take less than 500, more than 500 probably, but we never treat the numbers, especially anticoagulants. All the experts will agree with me. And NT-proBNP usually will take less than 125 picogram per ml is the normal, but we don't have an age-based range. I discussed with cardiologists also recently for that. And there is a question, and well, maybe Winsley or Valsan can take. Is there any predicted time? When will the next wave will storm us?
So you need to be an astrologer actually for that.
Okay, that's
so,
fine.
I mean, I think one thing we can say is whether, I mean, we don't know whether there'll be a third wave or whatever. But I think it's important to recognize that even if there was a third wave, I don't think it will be any different among children. It's not like that children will be more severely affected than they are right now. I think that's one. And also, if you actually look at the number of children who get infected right now, I mean, these are children who get infected from adults because the adults are all home, are all sitting around with the lockdown and everybody is at home. So they are getting infected from the adults. So it's not like the children will get more infected once they go to school. And we have good data to say that unlike flu, COVID-19 does not transmit as effectively among children like flu. Like, it's among the adults, the transmission is actually much better than among children. So I think for all these reasons, I mean, this thing is whether third wave or not, I cannot predict. But if there is even if there is a third wave, I think children are less likely to be, more affected than what they are right now.
Sure. In connection with that, it's fine. We are not astrologers, I agree. We don't know the time, but it's good to be prudent, to be prepared. Secondary hospital level, what is your advice and preparedness? In a quick 30 seconds answer.
So okay, I think you probably should ask everybody. I'll just start off. So I think it's important that for people to recognize MISC. So which I think is the one big message, even though the MISC incidence is low, it's actually a very severe disease which need to be recognized. That's my one bit.
Absolutely, yes, that's true. And in allergic patients about vaccine, again they asked, those who are allergic to penicillin, can we give vaccines? The answer is yes, I suppose.
The answer is yes. The unfortunate thing is the only thing that's mentioned as a contraindication is an allergy to any component of the COVID vaccine, which means you won't know unless you've taken it. There are things like polyethylene glycol and other things which are part of it. But generally, if you have a history of allergy, there is no contraindication for taking vaccine.
Sure. If anybody wants to ask, you can ask directly through the Zoom as well. And there is a question on CT scan, role of CT scan in newborn and young children. Is there any guidelines?
In fact, we would advise not doing a CT scan, number one. We advise not doing an X-ray in someone with mild disease, number two. Number three, if you have a child with moderate disease, which is tachypnea and a normal saturation or maintaining saturation on 94 at 2 liters, there's a little, if you don't have clinical findings of a pleural effusion or a consolidation, I would say the benefit of even an X-ray for moderate disease is very, very little. I presented some of the X-ray findings. Most of the time, you're just going to get a viral pneumonia-like pattern. So no CT, and benefit of X-ray more for severe disease or critical disease.
Okay, thank you. And Dr. Valsan talked about long COVID. Dr. Raju is asked, is long COVID is really an issue with children?
Long COVID actually has been described a lot in adults. People have just started looking at it, in the sense, even the largest series of long COVID in adults, they have not actually worked up these people to see whether their breathlessness, palpitations have underlying cardiac issues or respiratory issues. In children, it's not a major issue. There have been literally 3 small case series, a total of 25 children, most of them complaining of fatigue, something like what you would feel like after you get chikungunya infection, you end up having myalgia for a long time. It's not a major issue. I would say should not worry about it. Children tend to recover very fast. There was one other question on IL-6. So someone actually
It's a trend. I answered that. IL-6 levels are, it's about the trend. How will you interpret? So it is quite, because it is quite disproportionate only, I have to see. We have been doing IL-6 of late now, not in the previous first wave.
Yeah.
Even a child who is presenting with severe shock, initially the IL-6 is low. But you need to see the trend. We have seen one child only has gone into cytokine storm. Yes, that child had a very high in thousands. That child we gave tocilizumab. So I don't think one value is of, maybe we have to see the trend.
The other thing, about the other point is, I think there are a lot of centers which are doing IL-6s for everyone. The value of, I agree with you, the value of a single IL-6, I don't know. But in children, the value of an IL-6 itself, Sathish, would you agree with me? You'd probably do it only if you thought this child was non-responsive or refractory.
So, Valsan, CRP is a very good surrogate marker for IL-6.
Exactly.
So, instead of doing IL-6, we monitor only CRP, how they are doing, how they are feeling and all. So, we don't do IL-6 routinely for monitoring. As Ebor said, we are recently doing, we also don't know sometimes what to do with that. So, we are following CRP.
But I would say the trend, and it will tell us if there is no response, or if you call refractory disease, we mostly go by clinical values and the CRP.
Yeah.
And IL-6 may add on to that.
Exactly.
And
Sorry,
so I'll just quickly.
No, what I'm saying, you don't need the IL-6 most of the time.
Exactly. So don't get worried. I cannot do IL-6 in our hospital. Don't worry.
Yeah.
It's not going to give.
So this IL-6 D-dimer or a little bit of a newer thing to our pediatric population. So we don't know. And Valsan and Dr. Rose, somebody has asked, what is your opinion about school reopening? As a doctor, can you just show us the type of mask children should wear?
I did quote that IAP guideline, which is December 2020, IAP guideline on school reopening. So I did mention only the epidemiological criteria. The issue is that's a lot of it is taken, after the CDC criteria, which says you bus the children in separately, you have social distancing in the classroom, you have hand sanitizer, you wear masks. A lot of it is not practical for a place like a government school. But if you have to open a school, I mean, those are guidelines that you can take a look at. How masking, to be very frank, I think what they are doing in the US is they're actually advising masks and face shields in certain schools, but more than anything else, mask plus distancing. So which means in any one class, if you're going to maintain a 1 meter distance, I am a little, knowing our own schools and classrooms, I don't know how many children you can fit into one classroom.
Sure. There is a question on POCUS, that is the point of care lung and cardiac ultrasound modules in screening and monitoring Missi. Yes, it is very much useful. When the patient comes to ICU, we do screen the heart to see the ejection fraction and how the cardiac contractility. Rarely the children go in for it. That means if they are in severe cardiac dysfunction, they go in for lung, that is pulmonary edema. So it is useful. But we do get cardiac echo, that means by cardiologists to do the echo to see the coronary arteries. So it's not only the function, then we need to get echo done by cardiologists. But yes, there is usefulness of this POCUS, point of care lung and cardiac ultrasound in Missi management in ICUs. And
there are questions on fungal infection, Ebor.
Yeah, fungal infection in COVID children on steroids. Valsan?
I don't think we've seen any mucor, for instance, which is actually the topic of interest nowadays. We do see mucor with normally with conditions like acute leukemias. So if you have, like Winsley was presenting, if you already have a predisposing condition, then you are likely to have a fungal infection. But we've not seen, any proved COVID associated mucor in ICU. Ebor, anything recently?
Which are no. We had 2 children with mucor.
Yeah, but
they were, but non-COVID. One was child with diabetic ketoacidosis presentation and was on a mild low dose steroids and for the septic shock, but the child had, and another one child, but they are all non-COVID. Yes. And
again,
yeah,
steroids we are
Sathish.
using only for the MISC. MISC usually comes for a well children without any comorbid factors. Most of the children are well children. Their immune system is overactive. So we give steroids maximum of 2 to 3 weeks. That we are very particular about this high dose steroids. We try to avoid high dose steroids, maximum 1 or 2 milligram per kilogram, and we don't taper for long term and all. We stop it abruptly in 10 to 15 days.
Yeah. So the incident of Missi, yeah, go ahead, Sathish.
No, there is some question called cytosorb in cytokine storm. What is your experience? I don't know what is the Dr. Sudhir Kumar. I never heard what is called cytosorb.
No, that is intensivists use that. Cytosorb is it's a filter which can be used for when we do the CRRT or in that dialysis we can use a cytosorb. One filter is about 1 lakh. And it's been used in adult COVID cytokine storm. That is an acute COVID cytokine storm. But we don't have an experience. Probably in well advanced and resource unlimited centers, they might use it in children. And what are the incidents of Missi? Who talked about you? 1 in lakh affected children or general population?
General population. It's not affected
children. General population. Yes, that is the question.
So I think we should remember out of we've had about 1,000 children with COVID-19. And we've had about 30 children with Missi.
Yeah.
So it's actually
30. Now this second wave is 25 so far. The first wave is 18. 43 children you're seeing.
So 43 out of 1,000 children who've been diagnosed with COVID-19. So it's definitely, I mean, it's 1 per lakh population and not
not children who are having respiratory disease like asthma will be at more risk. Some other question was also on cystic fibrosis children. How can we prevent that? So can you take this, Valsan and Winsley?
Asthma specifically, no increased risk. Cystic fibrosis would depend on whether you have bronchiectasis. If you have severe bronchiectasis, then you are actually going to take a longer time to clear the infection. But on the whole, most of the cystic fibrosis and asthma registries in Europe have not actually reported, any increased incidence of severity with COVID-19. There was one question on Maharashtra reporting 8,000 cases in a week. And I think right after that, 2 days later, Maharashtra's health, department released a press release saying that the proportions of pediatric was still the same. And I think that's the time at which they were going out and testing everybody in the community, whether they were asymptomatic or not. So this 8,000 cases in a week includes a lot of asymptomatics, mild, moderate, So asymptomatic is also one of these issues with regard to testing. Hospital testing tends to focus on those who come to hospital or who are contacts of adults. So you do miss some asymptomatics. If you were to test in the community, you will have large numbers. We know the numbers have been higher this year, but as far as proportions and severity go, it has been the same proportion and the same severity as last year.
Let's comment on cleanliness of flow meters and incidence of Legionella and other infections, including fungal infection, probably. And Dr. Vanitha Jagannath, expert of Missi treatment modalities have been assessed by extrapolating studies since no RCTs. Is the institution collaborative with UK best available treatment study? Any other important questions to be answered?
See, this UK, we have very close friend of us, Ebor also knows. We all know that Dr. Ramanan, who is an important lead in all the studies done in UK. We don't have a study collaboration, but even our treatment protocol, before we finalize, we discussed with him. We got input from him before we discussed.
So whether inhalational steroids given for asthma reduce risk of Missi? Will it reduce?
I don't think we have any evidence for that, Ebor.
Okay.
There's one question I actually wanted to answer. This is somebody's asked, surgical mask is loose for most children. Any alternative? I actually want to point you to a CDC video, which is on YouTube, which is called knotting and tucking your mask. So, and that's useful both for surgical masks and for cloth masks. So if you just go to YouTube and say knotting and tucking of mask CDC, it teaches you how to do it, So you make a knot, you tighten the mask and you are able to tuck it in and make a better fit. So, I'm sorry, I can't demonstrate it here.
Person, actually, it becomes like one N95 mask. I saw that video. It really makes it like one N95 mask.
It's very good, actually. And you can do that both, even for the cloth mask, because the cloth masks are also not really child specific.
So is rampant use of hand sanitizer in community risk of development of any kind of resistance in microbes in the long run?
So I think the important thing is it should have at least 60% alcohol for it to be effective. And if you dilute it and use it, I mean, like whether the microbe will become less resistant to alcohol, I don't know. But it actually doesn't make it more resistant to antibiotics that we would normally use. So I don't think that is a concern. But this thing will be ineffective if you use diluted hand sanitizer. So importantly, it should have at least 60% alcohol.
And I think the one thing that came up, I think from Spain or Italy, was increased eczema, in children, not so much in adults. But using hand sanitizer. So one option is also to remember to teach them soap is a very good thing to use. Not of course when you're walking around the place, but at least when you're at home.
I think we have maybe another questions. Anything? I'll just end up by what we follow in the Missi. Sathish has already shown. So this protocol, we are not doing any RCTs or anything. This is the protocol which we have formulated, and for this wave, all these 43 children which we have seen, sorry, not 43, this 25 children, we have put it in this group. So that is IAP, and many organizations have come out with many protocols. This is with the experience of our patients in the first wave and in this. So as Sathish said, we have put in 3 groups. There's febrile inflammatory, there is no shock danger we may observe. But if they are ill appearing and needs hospitalization, we will still low dose, whether it is a DEXA or a methyl. The second component is the major. They may come into ICU mostly. So here the question is, any shock patients has to be received IVIG. That's what the ACR guideline says. But our experience is most of the shock just resolve within 6 to 12 hours. They just give volume. They may come out with one adrenaline with a low dose. Yes. So that we categorize them as moderate. We give only 2 milligram per kg, but we'll closely follow them for 36 and 48 hours. 36 to 48 hours, the response should be there, where we have put the response has to be deference of fever, CRP has to be less than 70% of baseline. If it not, we'll consider 10 mg per kg, or by the time culture would have been come, and an IVIG also with discussion with the rheumatologist. The other 2 we know, if they are severe with a myocardial dysfunction, no question, IVIG and a methylprednisolone. And an organ threatening also we have seen, that's without shock. They may come with 2 or more organ involvement, and then we give IVIG. The third group also, there is no discussion. It is all in the rheumatology, KD like incomplete or complete or MAS. So that is also not a criteria, not a problem in differentiating giving IVIG. So in this group only, we take this opportunity to give the methyl at low dose, but we closely follow them up. So Any comments, Sathish and others? Because in the protocol which we formed, we are all involved, and the refractory disease, yes, we will give the intensification treatment.
Yeah, see the shock phenotype, as Ebor said, they don't have this. Usually the phenotype of Kawasaki disease has a chance of coronary artery involvement. That's why the IVIG we try to give, because steroids alone will not prevent that. That's from the experience again from the Kawasaki disease. This MIS is a new disease. So when somebody comes with only with shock, we give only steroids. And as Ebor said, we don't pulse them with steroids on day one. We always give low dose steroids. By the time culture comes, then if there is no improvement, definitely will go high.
Somebody has asked about the inotrope of choice in Missi patients. It as like other shock. That means if the pulse pressure is wide, provide warm shock, I would use norepinephrine. But mostly you need to know they may have a mild to severe cardiac dysfunction. In that, adrenaline may be the preferred inotrope of choice. So that we have to see at the bedside and decide. Cost of treatment of IVIG, Sathish has put 10 grams is 15,000.
So 2 grams per kg, maximum we go up to 70 grams. Some book says we can go up to 100 grams, but children, we try to keep it at 70, depending on the weight of the child.
You want to comment anything about aspirin, Sathish, in Missi?
Yeah, aspirin is very clearly said. Aspirin is very useful. Is again the KD phenotype, definitely we have to give, because or with somebody has got myocardial involvement, definitely we have to give aspirin 3 to 5 mg. There is no role of high dose aspirin what we use in Kawasaki disease in Missi. Only low dose aspirin, 3 to 5 milligram, maximum 75.
I wanted to make one comment on the febrile inflammatory, pathway. You must remember that you can have children with fever, inflammatory markers, who don't fit the Missi definition. So, so that is one of the things to watch out for when you make the diagnosis. Like Sathish said, not to over-diagnose Missi. So that is the main thing.
Yeah, Sudhir Kumar has asked the same question. Atypical kid, KD, yeah?
So,
that is for Sathish probably. Atypical KD, fever, rash with mild.
So again, IVIG is definite. Okay. So if they come, especially during this season, if the child is very small, they are more chance to have coronary artery involvement if we give steroids. In this condition now with the Missi phenotype, I think low dose steroids has to be given along with IVIG, 1 to 2 milligram of methylprednisolone.
And maybe to Valsan and Winsley. So we have also seen children coming with COVID antibodies positive and scrub positive, ELISA positive. And in previously dengue also positive. In another webinar when we were there, many people have asked about Vidal being positive and COVID antibodies as well. So how to go about?
Do we have any data on cross-reactive antibodies, Winsley?
So not to my knowledge, but I think we've done some zero surveys in the community, and even among children, about 40-45% of the children are actually seropositive. So I think at a time when there is so much of COVID going around, it is possible that you'll have two diseases happening at the same time. And it seems like even dengue and scrub typhus, it is the scrub typhus or the dengue which drives the clinical phenotype rather than COVID-19 in children.
So like Sathish said, you need to, these are things that you would need to, consider treating. If you are scrub positive and you're COVID positive, would you not give doxycycline? I think you would. So,
yeah, that is definitely doxy. See, our protocol also, as I put in that Missi, moderate shock or febrile inflammatory, whoever come to ICU will be investigated for all culture and tropical infections. And if we see an SR in this child who was scrub positive, there was an SR. But there was contact with COVID, CRP was elevated, D-dimer, everything was fitting into Missi. But we have started on doxy, and scrub also has come positive, COVID antibodies also positive. Child was in shock, requiring inotropes. So we gave the doxy as well as the low-dose methylprednisolone.
Exactly.
And
Because
that is
you
what
will-
initially we managed.
No, that's true,
Yeah.
because scrub can present with very severe, critical manifestations. So there's no harm in giving methylprednisolone along with doxy.
I think we can go on discussing about this for a long, and I think it's 5:47, 5:50. So I think many questions we have answered. I think this recording will be available, which is Dr. Thomas Ram has put in the chat box. You can have a look into that. As we discussed all about the impact of COVID in children, the burden and the overview and the Missi part and the prevention strategies. Hopefully it would have been useful. And as we are coming out of a peak, Missi is an important challenge which we are going to face and we are facing. And within a week, we have got about 16 patients. That's the burden which we may see. So that's what we have come out with the protocol, and we strictly follow. And multidisciplinary team is the important thing, and close observation and judicial use of fluids and inotropes in the shock management, as like any other shock, and considering the bacterial sepsis, tropical infection in our country, it's more rampant, so that also to be considered. Dr. Arlalan has asked about the pulse oximetry size in children. So in the probe wise, the mechanism principles are the same. The probe is a problem that adult and pediatric and infants we have. Infants for the finger as well as for the ear probe. Adult probe probably for a child who is little more than 8 years or so, who can be fit, the probe can fit into the thumb or the fingers can be used. And artifacts are problem, yes, especially when they have a poor perfusion, it may be difficult. The advanced technology is what is called a Massimo technology, where the pulse oximeter can filter the artifact and give a value. Other questions probably which I can answer. Sathish also has discussed about the Missi and can Missi seen even RT-PCR negative? That Dr. Sathish has mentioned the reply, as Missi is a post-inflammatory syndrome, RT-PCR may be negative, but there can be a small population that has put 30%, and we have also seen in the second wave, so far we have seen 25 children. Among that, 3 were RT-PCR positive, and the other 22 are RT-PCR negative and antibody positive. So there is a small proportion where they can have an RT-PCR positive and present like a multi-system inflammatory syndrome. And there is about IL-6, interleukin-6 in children, especially if the child is going into like a cytokine storm, we may, but otherwise it's very difficult to interpret and manage. We go clinically, how is the child? If shock means we will provide support with fluids and inotropes. But if the child is going and not responding to the initial treatment, and if the IL-6 is going up, probably the trend of the IL-6 might help in choosing intensification of the treatment. And some questions on the vaccines, and Dr. Valsan will take on that. And somebody has asked about the ESR value. Usually will take more than 40 millimeter per hour, and CRP is more than 5 milligram per deciliter. That's sort of the cutoff we use. So there is a question, Sathish, you want to answer dexamethasone versus methylprednisolone?
Okay, so because of the time, I didn't talk about that. Remember that these all are steroids. Dexamethasone, methylprednisolone, all are steroids. Dexamethasone came initially from the recovery trial because that's what used in the adults. And methylprednisolone is also the steroid. Dexamethasone has got very high potent steroid, lot of side effects, and it also.
So the answer to this, yes, we can use it. And it has is easily available. Probably it has been extrapolated from the recovery trial. That even in the first wave, we gave dexamethasone for all our children. Then in second wave only, we revised our protocol and we are giving methylprednisolone. So the answer, simple answer is yes, you can use dexa. Over to Dr. Thomas now.
Thank you, Dr. Ebor. On behalf of the COVID Command Center Training Desk, I would like to thank our moderator, Dr. Ebor, for conducting this session, and our support team, our speakers, for making the session very lively, very informative, and I think it was very timely that the session was conducted. And also special thanks to all our audience for, I would say, patiently participating in this session. I think is one of our longest sessions we have had. I think we have crossed more than 90 minutes, but you kept it very lively. It was very interactive. And we hope this session, which is shared by experts, was very meaningful to all of you. And as shared in the chat box, this session should be available as a recording within 2 days. And it will be hosted on our COVID Pulse playlist on the YouTube channel of CMC, and it can be accessed over there. So thank you all of you for participating, and have a good evening, a safe evening, and God bless all of you. Thank you.